All right, we're back with our series. We've got 5 studies on the docket tonight, and we're starting off with the effect of conservative treatment on greater trochanteric pain syndrome. So basically, this is going to be hip pain. So if we can kind of think of my forearm as our thigh, so we've got the thigh, and then we've got the actual femur where we've got the ball comes into the socket. Everything around here on that outermost knobby area is going to be where this is talking about as far as how effective treatment is. And what they found was through the 19 randomized controlled trials involving almost 2,000 participants, they found that exercise therapy, going to the conclusion here, exercise therapy was the thing to do for it. And there's a lot of reasons for that. Kind of like low back pain or non-specific low back pain, this syndrome is more or less just a conglomeration of symptoms that you have in that area that people will treat. But that area has a lot to it. So it could be you have gluteal tendinopathy, which is going to be around that area, in which case you have to treat accordingly, targeting the gluteal muscles and tendons and manage that accordingly. It's going to benefit greatly from exercise. There could be aspects of the pelvic floor that is not right for some reason, that through different muscular ties is affecting pain in that region, in which case you got to target pelvic floor musculature via an exercise program and it'll get better. So I'm not surprised that this is stated this way. It reaffirmed the superiority of exercise therapy in the treatment of that greater trochanteric pain syndrome. It also found in these randomized controlled trials that there was effectiveness of injection combined with physical modalities, which, again, if you paid any attention to this series so far, if you're not a first-time customer, we've gone over that, especially in the short term. If we're dealing with a musculoskeletal issue, these can be a treatment option. Now, again, like a lot of other things, I do think that they're used too much too soon for too many things, but we have to admit that for the right person at the right time, they are still effective. I also like this, that they're trying to spur future conservative treatments for various tendinopathies. Again, I just like this study. It's an area that isn't given enough attention, is somewhat nebulous. I'm glad that more research is coming out for reinforcing some of the tried and true methods and exercising some pursuit to other treatment models, because this isn't just injection, it's injection and physical modalities. That could be a lot of different things. That could be instrument assisted work, that could be a different modality like shockwave therapy. More research has to be done to see if there are additional conservative treatment strategies, like it says here, for this condition. So I like the fact that this is being studied. It reinforces our bias and how we like to treat, and it's open to showing that there may be other potential treatment options out there for, again, sometimes a tricky to pin down syndrome. It's actually almost like anybody who walks up to me and says, well, I have plantar fasciitis. Well, why do you think you have that? I've got foot pain. It's kind of like that comic. Like, do you know how little that actually narrows it down? Same thing when people just categorize non-specific low back pain. Oh, I just have non-specific low back pain. There could be a lot to that. Or I have, GTPS. I have greater trochanteric pain syndrome. It's like, all right, is that the glutes? Is that the pelvic floor? Is that some tie into the low back? Is that something to deal with the quad musculature wrapping around? I shouldn't say quad muscular wrapping around. They go up front, but because of issues and how the body's tied together, I'm getting off topic. We're going to move on to the next study before I talk myself into a hole here. This one, I like this one. Do psychological factors explain the persistence of symptoms in individuals with rotator cuff related shoulder pain? This one's a prospective cohort study. So the key things about this is that they had not the smallest group I've seen, almost 150 people with persistent rotator cuff persistent pain. They basically had them take a self-reported questionnaire. So how is your condition? How is the pain? And asked them all these different things: pain, disability, what do they think and feel about this condition? How resilient are they? How stressed are they? Do they really fear and dread what is going on? Do they have anxiety? Do they have depression? Do they have management strategies already for pain? And do they have a social support network? After that, they took an educational program at trying to promote self-management that included just 2 meetings with a physiotherapist. They measured at 12 and 24 weeks, and they filled out the same questionnaires again, and they figured out what happened. This is kind of cool. I'm actually going to go through the results on this one. So skipping all of that different thing, the poison regression, it showed that higher perceived stress, if you catastrophized or really played up your condition too much, symptoms of depression, anxiety, and a generalized lower resilience were associated with ongoing pain at 12 weeks. In addition, reduced pain self-efficacy was associated with persistent pain at both 12 weeks and 24 weeks. Multivariate regression indicated that only pain self-efficacy served as a protective factor against persistent shoulder cuff pain. So what does this mean? Why is this cool? Well, because we're more than just our physical tissues here, there is a ton that goes into a person's perception of pain, an absolute metric ton. I've given workshops on this. They're scratching the surface. I've got multiple books on that, and they can be generally confusing because not everybody agrees on, terminology. Not everybody agrees on a classification system. Suffice it to say, pain is complex, multifactorial, and you actually can't really gauge who's going to feel what level of pain based upon your perception of their injury. I'll do this little experiment with you guys. If we picture a paper cut, if I just go right across my finger, we all know that that is going to hurt exquisitely, but there's not a lot of damage there, right? It's literally just a cut. My skin is cut just enough for it to bleed, but I have all of my nerves going like pain, 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 pain. Now let's flip the switch. Again, I saw this when I was an EMT. It's insane when you think about this. Picture any major accident, whether it is a car crash, a shark attack, anything where you are in danger. These people will not feel pain. Your brain just shuts off the signal. It's got stuff to do. It's got to get you out of danger. And very often you have to wait minutes, maybe hours, maybe even a day or two before you start feeling any pain from that actual event. So in the short term, paper cuts hurt worse than, a shark attack, somebody biting off your arm. Why am I saying this? Go back to this persistent pain. Your brain goes through this very complex triage mechanism to figure out what level of pain is acceptable in the moment to feel. It uses everything at its disposal, all of its resources, from its perception on its mental resources, its emotional resources, its physical resources and capacity, its economic resources, its support structure resources. All of these things play into and affect where that dial on that pain is set. And you could find a world-class, we'll just call him clinician, musculoskeletal clinician of any caliber or any variety, top caliber, who's treating all of the MSK stuff. If they don't address the rest of what your brain takes in as resources to figure out if it should feel pain or not, that pain may not go away. I tell people all the time, hey, if I do everything in the world to you, this 10 out of 10 pain may go down to a 6. If we start to tweak your diet, may go down to a 4. If we give you a means to actually get out, walk around, and exercise, may go down to a 2. And if we find somebody for you to talk to about these stressful situations that you're going on, then and only then might we actually be able to tell you that that pain will actually start to go away. But we got to be honest about it, and you are way more complex than just the physical injury. And this is highlighting that these people needed this educational resource to actually have a protective buffer against still feeling that pain. And those people that lacked some of those resources because the body had to allocate them somewhere else because they were feeling depressed, they had to take resources and deal with that. Because they were, stressing out about it, catastrophizing, they have a higher perceived stress. Your brain is shunting resources. It's going to dial up that pain and keep it there because it has to. It's what it does. But those people that had additional resources available because they had those support structures, because they didn't catastrophize, because they weren't dealing with a higher level of anxiety or stress, they were able to have that buffer and turn that dial down. So I really, really like that. Again, a lot of these studies bias what we do. We actually put people through a yellow flag questionnaire where we're going to be asking them questions about, hey, not only what do you feel about, or what level is your pain, what is your diet, how are you sleeping, what is your level of stress, essentially where's your head at, especially regarding this injury. So this is just really, really cool, and I hope that I didn't bore everybody and make you go cross-eyed here, but we've got 3 other studies to get through. 2 of them are relatively quick, and we'll finish on the last one. Who knew? All right, so this one is recurrent sprains of chronic ankle instability with chronic syndesmotic injury. And basically, what is it correlated with? It's correlated with what's in the title, plantar flexion instability, and this is despite multisensory benefits. All right, doc, what the heck did you just say? Basically, ankle sprains, chronic ankle sprains, with what's called a syndesmotic injury. What's a syndesmotic injury? Well, especially high ankle sprains, you stress additional tissues that are above the actual ankle joint. So if you didn't catch it, the foot is one of the most, if not the most complicated joint mechanism structure in the entire human body. And if we kind of see if I can get this in picture here. So if we pretend that my hand is a foot, my wrist is the actual ankle, and my forearm is your shin bone, you have 2 bones in the shin. You have the tibia and you have the fibula. What's keeping those 2 together is this interconnected tissue called the syndesmosis. With an ankle sprain, especially as you roll that ankle, those bones may twist enough where you actually start to damage that syndesmotic tissue, especially in a higher ankle sprain. So what they did is they really broke down what we should essentially target with these people. And that is what's called plantar flexion. So if you go up onto your toes or you do a calf raise, that is plantar flexion. And anybody who has recurrent ankle sprains can tell you, and I've done it a few times, when I go to walk and I toe off to my back foot as I'm trying to propel myself forward, and as my foot initially touches ground, and it's usually when it first touches ground, when the ball of my foot kind of touches or the mid part of my foot touches and I'm still in that little bit of a toe off angle, that's when for some reason my ankle will just go off to the side and I'm at risk of injuring it again and rolling it again. I'll say I have stupid ankles. That's why I try and train them, and I should probably train them more. But what they found was the correlation shows higher sprain incidence with plantar flexion instability, and they actually jumped down to the conclusion. They basically say that that's what we should target. So that motion, that at risk moment when you're walking, running, playing, etc., is something that may be desirable to target because it had the highest risk of recurring ankle sprains, despite additional coexisting multisensory benefits. So basically, you go through a bad enough ankle sprain, you're going to have the physical issues, the motor control issues, and because a lot of people, like myself included, I've had some ankle sprains so bad that I feel a zinger right along there, and I've damaged the nerve. I don't want to say that to scare anybody. Like, these nerves heal, they just suck. So this is saying, despite the sensory deficits in the area, they should still target plantar flexion, not in place of, but in addition to, and probably if you had to pick one, plantar flexion. Now, in my office, we're going to do it all, but it is something to highlight that we need to train that, if not first, definitely at some point during the rehab process, because that is the thing that is most at risk of this chronic ankle sprain. I don't want to call it a mechanism, but I have it. If I want to get better, I'm essentially going to train more plantar flexion. So rehabilitation should address these deficits, pain management, and targeted training. Everything that I fumbled along and eventually told you guys here. Now, the next study kind of backs it up and just showing that, hey, if you didn't think that last study showed that exercise and training was effective for reducing chronic ankle instability, oh, look, a meta-analysis essentially saying through all of this data, the same thing. After categorizing exercise type, the results indicate that strength training was more effective overall. Joint mobilization was also effective, and proprioceptive training was effective in improving your markers for ankle stability. So in conclusion, long-term multifaceted exercise therapy demonstrates superior rehab for patients with chronic ankle instability. Personalized treatment plans, what we're great at, informed by your assessment results, should prioritize targeted interventions like the last study, hint, hint, wink, wink, nudge, nudge, including joint mobilization if warranted, strength training, obviously, or proprioceptive training. Yeah, you're going to get that too. It holds great theoretical and practical value, optimizing chronic ankle instability treatment strategies and enhancing patient outcomes. Man, we're on a roll. So you know what? I'm not going to dilly-dally on that one, and we're just going to go right into our last study. Evaluating the impact of cervical stabilization exercises on chronic neck pain, a systematic review. This one's a little bit passionate for me just because I seem to have gotten the dole of patients recently who are having chronic neck pain who for some reason never receive any neck stabilization exercises whatsoever. Nobody actually tries to train the neck when it's in pain. Everybody always gets massages, they get instrument work, they get stretches, they get injections, but for some reason, when it comes to the neck itself and a few other joints in the body, we just don't train the sucker. And I, frankly, if I had hair, I'd pull it out. It's frustrating beyond belief. In fact, I just had a patient today where this was the case. This person has been suffering for months. They see trusted providers, and I'm going to be working with them in addition to those providers to do what the other ones have not, and that is to add stabilization exercises to this mixture to actually move the needle forward here. So let's get to the study, because if I ramble here, I'll be here until basically I have to go to bed. So chronic neck pain impacts a lot of people. It's a bugger. They wanted to see if these stabilization exercises helped in alleviating pain, improving function, and enhancing quality of life with that chronic neck pain. It was a systematic review following their guidelines. Let's skip that. And they basically looked at randomized controlled trials published within the last 10 years. So here's the results. 12 studies met the criteria, with most rated at moderate to high quality. So we're off to a good start. The findings demonstrated that these exercises, the stability exercises, significantly reduced pain, improved functional capacity, and because some studies are set up for postural stuff, correct postural abnormalities such as forward head posture. Now, again, I have my opinions on this. And again, for me, it's one of those things where some people have conditions like a Dowager's hump and a hyperkyphotic condition. They're not going to be able to fix this because it's structural. Same thing with certain scolioses or torticollises. So I'm personally not as concerned with this last part as far as a structural abnormality. Now, if it's self-induced and egregious, where you're not giving yourself any break from using technology and you are here 24/7, 365, okay, we'll have a talk. But I'm more concerned about the fact that it reduced pain and improved functional capacity with these people. So multimodal interventions combined, and I'm pretty sure we're going to see what I usually do in the office here. These exercises with manual therapy, something we're great at here. Thermotherapy, okay, I'll admit it, we don't have a lot of hot and cold devices in the office, so we'll skip that part for me. Or dynamic exercises yielded superior outcomes to the neck exercises alone. Intervention duration of 6 to 8 weeks was most effective in the studied group, and variable outcomes is attributed to differences in population characteristics and methodological quality. Basically, different studies yielded slightly different results, but they chalk that up to those variables. So long story short, these exercises are effective, evidence-based for managing chronic neck pain, tailored programs, what we're great at, particularly those integrating those multimodal approaches, which we can offer because we take time with you, enhance therapeutic outcomes, and future research should focus on long-term effects and subpopulation-specific benefits to optimize clinical implementation. So again, man, each one of these studies, it's reinforcing what we do, why we do the way we do it. We give you the time we need to work together to incorporate all of these evidence-based practices to give you all the best shot that I know how to give you for these conditions that we're discussing with you, not just today, but in the past and in the future. So this just really reinforces that I'm not going to change what I'm doing. I'm not going to go the quick route. I'm not going to do short little 10-minute, 5-minute visits. I'm not going to isolate myself to just a single service, whether that is manual therapy or adjusting or dry needling or rehab. I'm going to keep doing things the way that we know works, and that is this multimodal approach with active interventions, exercise therapy, passive interventions, that multimodal manual therapy side, and collaborating with required colleagues, physicians, therapists to give everybody here the best shot that they've got. But that's all I've got. I can ramble on for a lot longer, but I think this video is long enough. Thank you.